We'll move on to our next session on palliative care and rehabilitation. I'd like to invite the chairpersons for this session. Dr. Partho Mukherjee, Consultant Oncologist, Peerless Hospital, and Dr. Devashish Jatua Sir, Consultant Palliative Care Physician at CNCI Kolkata. I'd like to invite the first speaker for this session, Dr. Anurag Sarkar from CNCI.
Good afternoon, everyone. I'd like to express my gratitude and thanks to the organizing committee for having me here. So I'll speak on this topic on introduction of palliative care, just the basic things, because 15 minutes is not enough to describe everything. So I'll start with the introduction, a brief history, who gets palliation, the need for palliation, aspects of palliative care, what we do, and the conclusion. So my introduction would be starting with the definition of palliative care. So palliative care is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So it's a big definition. When we read through and through, we won't be able to understand what it actually means. So if I break it, then only you will get what actually palliative care means. And if we say that palliative care is an approach that improves the quality of life. So the primary purpose of palliative care is to improve the quality of life, that is the sense of well-being, and of whom it is of the patient as well as the family. So not just the patient that we're taking care of, but also the family members that we're taking care of, and of the patients who are facing life-threatening illnesses. So what we do there, after that we do an impeccable assessment, that is a thorough assessment and treatment of different symptoms, which can be physical symptoms, then psychosocial symptoms, and spiritual symptoms. So the concept of palliative care started early in the 1930s when there was a lot of medical neglects against the people who were critically ill and dying. So it started with various pioneers in palliative cares. So I'll discuss a few names, first among which is Dame Cecily Mary Saunders. She started the modern palliative care movement, which when she was young, she wanted to be a nurse initially, but because of the pressure from their family, she had to follow economics and other subjects. At that time, there was a breakout of the World War, and then she felt the need of palliation when she saw that all the critically ill patients were being ignored and neglected and were being sent home. So she started nursing at that point, but because of the physical limitations, she had to switch her career to social working. But even with that also, it was not enough, because she could not exactly take care of all those patients who actually needed maybe something beyond only care. Maybe they needed medical care, but she could not do that. After discussion with a surgeon, she changed her profession to being a doctor. So she has done initially nursing, then social work, and then followed by being a doctor. And then she opened up St. Christopher's Hospice, London, in which she used to admit all the patients who were critically ill with life-threatening illness, and who were the persons dying at that point. And she used to do a lot of research and presented with the concept of total pain at that point. And then we have Dr. Balfour Mount. He was a surgeon from Canada, and he coined the term palliative care, which is something which is beyond hospice. So hospice was meant for only the end of life and the patients with life-limiting illness for the last few months of their life. But palliative care, when Sir Balfour Mount started that, so it was also including the inpatient care. Along with that, there was OPD consultations, then hospice care, then home care. All those things were also included. So he widened the vision of palliative care. And then Dr. Robert Krikos, who pioneered the pioneer of hospice movement during the 1970s. So when we talk about hospice, we have to know what is the meaning of hospice. So hospice comes from the Latin word hospitum, which means hospitality. It's not just that it's not like the concept which has come in few years or maybe in few decades. It is a prolonged process which started in the Middle Ages. So we had these guest houses which were used by the religious orders to offer special hospitality to the maybe the travelers and the pilgrims who used to come travel a lot and then might have felt sick, and they were being taken care of at those places, and also of the ill and dying patients. And when we talk about the history of palliative care in India, so it is a deep-rooted history starting from the time of the Emperor Ashoka. They had developed a lot of refugee camps along the along the Ganges river near Varanasi, and those were used by the clinically ill, terminally ill patients who were facing problems with life-threatening illnesses. And then these concepts are now used in the evolution of palliative medicine, and we started our palliative care movement with the birth of Shanti Avedna Hospice in Mumbai in the year of 1986. And then followed by a lot of development of a lot of societies like Pain and Palliative Care Society established in 1993, then Indian Association of Palliative Care in 1994, followed by our first conference in Varanasi in 1994. And also there were development of cancer support. We had our first MD in palliative medicine in the year 2012, followed by DNB courses started recently in 2021. So what are the goals of palliative care? So when we talk about the goals, it's always about the quality of life, as you have also seen in the definition that we talk about the quality of life. And what do you mean by the quality of life? It's something which would give us a sense of well-being, like something that would make us happy. It's for a patient who is already terminally ill and not able to move, he might know that he is about to die. So what would give him a good quality of life or a sense of well-being? It is a sense of control that would give him a good quality of life. So something, maybe a small thing that he wants, if he is able to do that, that will improve his quality of life. And so that's why we need a patient's goal concordant care. So it's not just that we are offering a treatment and they are bound to take that. So we gave them options, that this is the option, number one option, that you can get chemotherapy or radiation therapy for a cancer patient being treated. Or maybe there is another option like palliative medicine, palliative care, in which you don't get chemotherapy, just the comfort and care with which there will be no symptoms, but you will be able to live in a good way. So after that, the patient might, or the third option we can give is that now because you have this disease which is not curable, so you can just spend the rest of your life at your home with your family members or any other places where you want to go. So in a way, so we are giving them options, and they have this sense of control that they are having these options to choose. So they can choose the most favorable thing that they want, which is important to them. So that would ultimately improve their goals, quality of life. So one is the quality of life, and the second is the improvement in the quality of death. So how does it help? It like I have told in the definition also, it's not about just the patient but also of the family. So quality of death would be less stressful for the patient if we improve that, as well as for the family, for the caregivers. It will be less traumatic for them, and waving a goodbye in a happy sense would make them cherish that, like not as a memory of suffering, but a memory of joy, maybe because of the transition in the next dimension. So in that way we support the family. Now, who provides palliative care? So ultimately we have so many things. It's not about the physical problem we're talking about, it's also the psychosocial, spiritual and other social problems, as well as support from other volunteers. So we just only a doctor, for a doctor it's not possible to provide all the care. We need a team, we need a multidisciplinary team that includes doctors, nurses, social worker, massage therapist, pharmacist, nutritionist, counselors and many more. The list is not ending.
5 minutes left.
And who receives palliative care? So these are the patients with chronic life-limiting and life-threatening illnesses like cancer, cardiac disease, kidney failure, Alzheimer's, HIV/AIDS, amyotrophic lateral sclerosis, and many other diseases. So there was a misconceptions earlier that palliative care means only the end of life care, and it was like that the curative treatment would be given in the earliest stages. When there was exhaustion of the curative treatment, only then palliative care would come till death. But now this the continuum of care follows like that, that it starts from the beginning of the illness, and maybe the curative treatment initially takes the leading position, but gradually with the exhaustion of the curative treatment, the role of the palliative care increases. And for the last 12 months after the end of the curative life prolonging treatment, there starts a period called the end of life care, and the last 6 months is called the hospice care till death. And even after death, we don't leave the hands of the family. We give bereavement care to the patient's relative. So there are few aspects of palliative care which we maintain to improve the quality of life of the patient as well as the family. So palliative care affirms life and regards death as a normal process. So until and unless the patient feels that death is inevitable, death cannot be avoided, and if they continue to deny death, so the it will worsen their quality of life, because something which would happen and which they are not able to accept. So we need to counsel them and make them understand that it is not something that is not in our hand. So we have to explain them in that way. Then palliative care intends neither to hasten nor postpone death. So the aim is not to cure the illness or to prolong the suffering. So we need to reduce the suffering and ultimately improve the quality of life. Then palliative care integrates the psychological and spiritual aspects of patient's care. Like I said, that James Cecil Saunders introduced the term total pain. So it not only includes the physical symptoms like the pain and other symptoms, but also social, psychological and spiritual symptoms which need to be addressed at the same time. And each of the other factors increases the physical symptoms, or maybe because of the physical symptoms there would be increase in the psychological or spiritual symptoms. So all these things need to be addressed at one go. Then palliative care offers support system to help patients live as actively possible until death. So we know that we can't control how long the patient is going to live. We don't have that in our hand, but we can definitely control how the patient is going to live. In what way they can live, what feels important to them, that can be controlled. So it will ultimately improve their quality of life.
Just over a minute left.
Okay. Palliative care offers support system to help the family cope during the patient's illness and in their own bereavement. So it's not just the patient need, but also the carer's need. So we need to think about that also. First, the carer is taking care of the patient whole time. From day in and day out, they are taking care for 24 hours. They might have left their own job to take care of the patient. So it's the suffering of the patient also makes them suffer. So we have to take care of that. First of all, we have to acknowledge that there is a problem in managing the patient. We can tell them how to go on with managing the patient in an easy way, so that they can have less stress. So what we can do is explain them about the patient's prognosis, how to manage the symptoms, what services are available, how to care for the patients, and sudden changes in condition and what to do, and insight on how the patient might die if the relatives or caregivers want to know about that. And also the needs of the carer. It can be also practical and domestic health, because the patient, the caregiver is already invested their whole time in taking care of the patient. So practical and domestic help might be useful. Psychological, financial and spiritual help can help the patient and caregiver. And after death of the patient, then we can provide bereavement care to the patient's caregiver, so that they can come back to the normal life, because their whole time was earlier invested in the care of the patient. Now the patient is gone, and the whole time they would just think about the traumatic experience that they have gained over time in caring of the patient. So we have to provide bereavement care so that the patient's caregiver can come back to normal life. So in all these things, one of the most important thing is communication, because it helps us shape how the patient thinks, how the relative thinks, how we can go forward with managing the disease as well as improving the symptoms. So it is absolutely vital. It helps in breaking the bad news, like the breaking of the having a cancer or a life-limiting illness. Then also in breaking denial, facing difficult questions, and then we can acknowledge emotional reaction through communication. What we use is the spikes protocol in breaking bad news. So I won't go into the details. You can find it in Google also. And other thing is that often people misunderstand palliative care as hospice care or the last. They don't understand the difference. So hospice care is a part of palliative care which is being provided in the last 6 months of life, just to provide comfort and facilitate a dignified death. So what we do at palliative in palliative care at CNCI Kolkata, so we have a 15-bedded hospice along with the OPD and also inpatient consultations that we do along with neurological interventions that are being done in our institute to provide a good palliative care. And also we provide free home care service to the patients who need them. And that has been a good thing. And also we have ongoing training programs in CNCI. We have a six-week certificate course in palliative medicine in collaboration with the government of West Bengal, along with Part B training, that is a certificate course in essential of palliative care by the IAPC. And to summarize, we have to recognize the symptoms, we have to identify the patient's goals and needs, and we have to help to facilitate difficult conversation and also assist with the advanced care directive so as to have a control in their life. So that is ultimately going to improve their quality of life. And last, I'll end with this statement: the power of healing does not lie in just prescribing drug and medical treatment. What it essentially requires is caring for the patients. Thank you.
Thank you, Doc, for a nice presentation. And we'll take questions at the end of the session.
Okay.